Hi everyone, in this video, a quick review of the Pediatric Bradycardia with Poor Perfusion algorithm starting right now. Okay, so starting at the top of this algorithm, of course it says ensure your own safety, and if you're responding in the field, you want to make sure the scene is safe before we go into it. Next, moving down, determine that the child has a bradycardia. How do you do that? You check a pulse. So you find that this child has a slow heart rate. Now I want to move over to the side of the algorithm and look at the causes of bradycardia in a child. Number one cause, hands down, bar none, hypoxia. Hypoxia can cause bradycardia in kids. Why does this happen? It is believed, the theory is that it may be an evolutionary throwback associated with the mammalian diving reflex. And this is a reflex that aquatic mammals have, like whales, big seals. And what this reflex does is when the animal dives down to the bottom of the ocean to get food, to have lunch, this reflex causes their heart rate to slow dramatically, so their oxygen consumption drops. They're not using up all this oxygen, so they can go down to the bottom of the ocean, have some squid, have some krill, and not die. Come back up, take another breath, and the whole thing starts over again. So hypoxia has to be ruled out first, which means you want to get that airway open, ensure that air is getting into that child and air is coming out of that child. That is your first priority. Other causes they cite, hypothermia. This is going to be painfully obvious because the child is now a kidsicle. To be that cold to drop your heart rate is going to be obvious. After hypoxia, I'd really be looking at ingestion, medications. Did this kid get into something? Because kids get into everything. Did they take some of grandma's beta blockers, her calcium channel blockers? Was there an ingestion that is causing this bradycardia? But our focus and our number one concern is hypoxia. Next, moving down the algorithm, is this bradycardia causing a hemodynamic compromise, altered mental status, low blood pressure, signs of shock? If not, if you just showed up, the kid's bradycardic, but they're asymptomatic, no signs of anything going on, you're going to watch this kid like a hawk because children are not supposed to be bradycardic. That includes the administration of oxygen if needed. Use your SpO2 to guide that. Gain vascular access and get a 12 lead on this kid toot sweet because children should not be bradycardic. Now, if this child is showing signs of hemodynamic instability, and despite oxygenation and ventilation, we got an airway, we got air going in and out of this kid, and the heart rate still remains below 60, begin chest compressions immediately. Remember the rate, 100 to 120, and the depth is going to be 1/3 the distance anterior posterior through the chest. Now our strategy is try to figure out if hypoxia isn't the cause, what is the cause? We need to nail that down and find it. So the child is compromised, we're doing chest compressions. At this point, it's a lot like working in arrest. Again, we want to have the child intubated, secure that airway. Use SpO2 and capnography. We want to gain vascular access. And our first drug up to increase this child's heart rate is going to be epinephrine. And you might be thinking, well, geez, usually we give atropine to increase the heart rate. In an adult, in a child, we give epinephrine. And here's why, another thinking along with the mammalian diving reflex. Kids have a sticky gas pedal. Yep, they have a poorly developed sympathetic nervous system. And remember, in the body of the sympathetic, which is the gas pedal, the parasympathetic, which is the brake pedal, and they're both on all the time. In the adult, we would give a parasympathetic blocker like atropine, which takes your foot off the brake. And that leaves the gas pedal unopposed, and that'll increase the heart rate in an adult. But it's thought that kids literally have a sticky gas pedal, that underdeveloped sympathetic tone. So simply giving them atropine and taking our foot off the brake may not be sufficient to increase their heart rate. Therefore, our first drug to increase the heart rate in a child is our favorite sympathomimetic, epinephrine. The dosing, 0.01 milligrams per kilogram. And you can repeat this every 3 minutes just like you would do in an arrest. If epinephrine is ineffective and we've secured the airway, we know that hypoxia is not an issue, and we're going through the drawers and we're looking for drugs and other causes of this bradycardia, the second drug we would administer would then be atropine. The dose for atropine in a pediatric patient, 0.02 milligrams per kilogram. So In review, a bradycardic child, rule out hypoxia first. Establish and get that airway, we can get oxygen in, we can get CO2 out. If they are hemodynamically compromised with a pulse below 60, begin chest compressions, tube them, get a line. First drug up is epinephrine. And through all of this, we have someone else investigating and trying to find another cause for this bradycardia. Okay, this has been just a very quick review of the bradycardia with poor perfusion algorithm. My name is Mark. Thanks for watching. See you in the next video.